Assalamualaikum and good day. In this session, we are going to look at pathology of the stomach. This lecture is divided into three parts. The first part is going to look at the common congenital anomaly, acute gastritis, and stress-related mucosal disease. The second part will look at chronic gastritis and its complications, especially related to Helicobacter pylori, autoimmune atrophic gastritis, and peptic ulcer disease. The third and the last part we'll look into neoplastic and non-neoplastic polyps and cancers of the stomach, especially adenocarcinoma of the stomach. At the end of the lecture, the student will be able to list the common diseases of the stomach, discuss the important diseases of the stomach, discuss the pathophysiology of peptic ulcer disease, relationship of gastritis and carcinoma of the stomach, identify the neoplastic, non-neoplastic polyp of the stomach, and pre-malignant and malignant lesions of the stomach. The stomach is divided into four major anatomic regions: the cardia, fundus, body, and antrum. The cardia and antrum are lined mainly with mucin-secreting foveolar cells that form small glands. The antral glands are similar but also contain endocrine cells like G cells that release gastrin to stimulate luminal acid secretion by parietal cells. The well-developed glands of the body and fundus contain parietal cells as well as chief cells that produce and secrete digestive enzymes. Looking at the histological arrangement of the stomach is composed of the mucosa, the muscularis mucosa, submucosa, and the three layers of muscle, oblique, circular, and longitudinal, with the outer layer made up of the serosa. It is important to note that the main cells of the gastric mucosa is composed of the mucin-secreting foveolar cells, which secrete mucin and with high molecular weight glycoprotein. There's also the parietal cells, which secrete hydrogen and intrinsic factor, chief cells, which secrete pepsinogen that would be activated to pepsin in acidic condition, and endocrine cells, which secrete gastrin, histamine, somatostatin, and endothelin. It is important to note the major protectors of the gastric mucosa. Mucus and superficial cells secrete mucin and phospholipid, which avoid large food particles from directly touching the epithelium. They also secrete bicarbonate that create pH-neutral microenvironment in the middle of a very acidic gastric juice. They have tight intercellular junction as a barrier against the hydrogen ion, and they produce COX-dependent prostaglandin E2 and I2, which favors mucus, phospholipid, and bicarbonate secretion, inhibits hydrogen secretion, and causes vasodilatation, which causes increased mucosal blood flow. The rich mucosal blood flow provides oxygen, bicarbonate, and nutrients to the epithelial cells, and they also remove acid that may have diffused into the lamina propria. Another important note is superficial damage to the mucosa, that is confined to the mucosa, is called erosion, and it heals within hours to days. Whereas when damage extends beyond the muscularis mucosa through the submucosa, this is called gastric ulceration, and it will take weeks to heal. In this pathology of stomach, we will look at first congenital anomalies, and specifically congenital hypertrophic pyloric stenosis, gastropathy and acute gastritis, especially the ones that are caused by non-steroidal anti-inflammatory drugs, NSAIDs, stress-related mucosal disease, ulceration due to severe trauma, extensive burns, intracranial disease and shock, chronic gastritis and complication, especially the ones that are caused by Helicobacter pylori, autoimmune gastritis, and peptic ulcer disease. We will also look into the complications of chronic gastritis, such as intestinal metaplasia and dysplasia. We will look at two conditions of hypertrophic gastropathies, namely Menetrier disease and Zollinger-Ellison syndrome. And we will look at gastric polyps and tumors. For polyps, we will look at inflammatory and hyperplastic polyp, fundic gland polyp, and gastric adenoma. And for tumors, we will look at gastric adenocarcinoma, lymphoma, neuroendocrine neoplasms, and gastrointestinal stromal tumors. Congenital hypertrophic pyloric stenosis is a common congenital abnormality that affects 1 in 300 to 900 births. It results from progressive hypertrophy of muscularis propria of the pylorus. It's more common in males. The onset is about 3 to 12 weeks of life. There's higher concordance rate in monozygotic twins, Turner syndrome, and trisomy 18. It presents with regurgitation and projectile non-bilious vomiting after feeding, and physical examination will show about abdominal mass in about 90% of cases, and diagnosis is by ultrasound. Anatomically, you can see the hyperplasia of the pyloric muscularis propria, and surgical splitting of the muscle is curative. Inflammation of the gastric mucosa occurs in many conditions and is called acute gastritis when neutrophils are present, and gastropathy when inflammatory cells are rare. Irritants such as NSAIDs, alcohol, and bile are the most common causes of gastropathy. Gastropathy and gastritis may be asymptomatic or associated with epigastric pain, nausea, and vomiting. In more severe cases, there may be mucosal erosion, ulceration, hemorrhage, hematemesis, melena, and rarely massive blood loss. The gastric lumen has a pH of close to 1, more than 1,000,000 times more acidic than the blood. This harsh environment contributes to digestion, but also has the potential to cause damage. Multiple mechanisms have evolved to protect the gastric mucosa, such as seen in this diagram. Gastropathy and gastritis occur when the damaging forces overwhelm the protective factors. In this slide, we look at NSAIDs-associated acute gastritis. There is inhibition of the cyclooxygenase, or COX, by NSAIDs. NSAIDs inhibit COX-dependent synthesis of prostaglandins E2 and I2, which contribute to nearly all of the defense mechanisms in the stomach, including mucus, bicarbonate, phospholipid secretion, mucosal blood flow, and epithelial restitution. They also reduce the acid secretion. Although COX-1 plays a larger role than COX-2, both isoenzymes contribute to mucosal protection. Thus, while the risk of NSAID-induced gastric injury is greatest with non-selective inhibitors such as aspirin, ibuprofen, and naproxen, selective COX-2 inhibitors such as celecoxib can also cause gastropathy or gastritis. Grossly, acute gastritis can show diffusely hyperemic gastric mucosa, and histologically, you can see mucosal disruption, but the muscularis mucosa is intact, so this is an erosion. High power examination shows infiltration by neutrophils within the mucosa. Acute gastritis may be asymptomatic or cause variable degrees of epigastric pain, nausea, and vomiting. In more severe cases, there can be mucosal erosion, just like what we saw just now, ulceration, hemorrhage, hematemesis, melena, or rarely massive blood loss. Now we look at stress-related mucosal disease. Stress-related mucosal disease occurs in patients with severe trauma, extensive burns, intracranial disease, major surgery, serious medical disease, and other forms of severe physiologic stress. In some cases, stress-related ulcers are given specific names based on location and clinical associations. For example, stress ulcers are most common in the setting of shock, sepsis, or severe trauma. Curling ulcers refer to ulcers occurring in the proximal duodenum in the context of severe burns or trauma, and Cushing ulcers refer to gastric, duodenal, and esophageal ulcers arising in those with intracranial disease. They have an elevated risk for perforation. Stress-related gastric mucosal injury is often related to local ischemia. This may be due to systemic hypotension or reduced blood flow caused by stress-induced splanchnic vasoconstriction. Upregulation and increased release of vasoconstrictor also contribute to ischemic gastric mucosal injury. Lesions associated with intracranial injury are thought to be caused by direct stimulation of vagal nuclei, which causes hypersecretion of gastric acid. Systemic acidosis may also contribute to mucosal injury by lowering the intracellular pH of mucosal cells and thus reducing the pH gradient that promotes washout of lamina propria acid. Stress-related gastric mucosal injury ranges from shallow erosions to lesions that penetrate the mucosa. Here we see multiple small circular mucosal defects and is stained dark brown by acid digestion of the extravasated blood. You can see here necrosis involves the full thickness of the mucosa, and in these cases healing is with minimal fibrosis, and compare this to damage in chronic gastritis where you have usually fibrosis. Patients with stress-related mucosal disease may have histologic evidence of gastric mucosal damage. They may require red cell transfusion. They can get complications such as perforation. Use of prophylactic proton pump inhibitor may blunt the impact of stress ulceration.